Good evening. Am I audible? Yeah.
Yeah, very much audible, Rajan.
I thank you. First of all, I would like to thank Dr. Sandeep Jasuja for giving me the opportunity. And my apologies and my bad luck that I am not physically be there in my hometown, Jaipur. And I think Ajay Sharma sir would agree, exigencies of service, somehow I was not able to join in person. But lovely to be here and listening to all great speakers. I'll try to share my screen. So is it visible?
Yes, very clearly. You can put on the show mode, please.
Yeah. So good evening to everyone. I think after the first two talks, most of the thing would be a repetition. Dr. Meet had covered most of the topics which I'm going to say, so pardon me for the repetition. So the thing I'm going to talk about is how I treat relapsed refractory DLBCL. So whenever we diagnose a case of DLBCL, actually we tell the patient that he's got a better kind of a malignancy which is imminently treatable. So 150,000 new cases of large cell lymphomas are diagnosed annually worldwide. 30% of all cases of NHL. Now, important thing is more than 60% can be told that they can be cured with R-CHOP. R-CHOP, as has been discussed, has stood the test of the time, but patients who do not respond to R-CHOP have a poor outcome. So this is the paper which had come, if there are residents here, it's a very nice review on DLBCL which had come in NEJM in 2021. So which had shown that so if the patient survive for 2 years after the diagnosis of DLBCL, it's almost a flat line. So you can say more than 60 to 70% would be cured of their disease. But the thing is, can we predict refractoriness or relapse at the diagnosis, at the initial diagnosis? The most important is clinical. First, we have to do a correct staging, risk stratification. And the first excellent lecture by ma'am was how to classify the lymphoma properly, newer emerging techniques and the biomarkers. Now, important is the prognosis of DLBCL. This is age-old IPI, which was original IPI. Now we have an age-adjusted IPI, which is IPI minus age and number of extranodal sites. But what I want to tell is about this NCC and IPI. Now, NCC and IPI has categorized age as a continuous variable, which gave age 41 to 61 points, 2 points and 3 points there. Now, with LDH ratio, ECOG, and outward state. So now we are going on to an NCC and IPI, which has a low risk, low intermediate, high intermediate, and high risk. So they better stratify. So we all should evolve and move on to an NCC and IPI. Now, this has already been covered in detail about the cell of original. This is the topic of interest and research. Now, we should all strive for, in the present era, we should try to get testing to determine the cell of origin. Gene expression profiling is the gold standard, as has been told. Now, historically been performed on RNA from fresh frozen tissues. Now, there are various algorithms which have been used and predictor score. So we all know there are two major subgroups, the GCB and an activated B cell type. Now, the drawbacks is that it is not available in clinical practice to most of us. Now, this has been covered. So either the Dana-Farber or NCI, which ma'am had already told. So this is very important. And so there may be an ABC, which may be favorable, or a GCB, which may be unfavorable. So we are moving into the times of gene expression profiling and better stratifying DLBCL. Now, this has been already talked, double hit and double expressor. Just to reiterate, double hit will contain translocation of MYC gene together with a realignment of BCL2 and of BCL6. If all three are there, then it's a triple hit. Now, double expressor, while all DLBCL with MYC translocations demonstrate increased MYC expression, some have overexpression of MYC due to other mechanisms. So that the easier thing is double expressor because we can identify by immunohistochemistry. Now, this has been shown that we all know that GCB1 does better than the activated B cell type. Now, if you see the double hit and the double expressor, The worst is the double hit type. The prognosis is really poor in the double hit subtype. Now, this is again is a paper which had reviewed in NEJM. Now, what are the biologic factors which are associated with outcomes in patients with DLBCL? The most important biomarker is cell of origin, and the molecular classification, which we have already discussed, the ABC subtype, is associated with poor prognosis as well as CNS relapse. We have those IHC-based algorithms, which again can be used, which is routinely available into GCB and non-GCBs, subgroups, double or triple hit, MYC and BCL2 protein expression. The important thing which is available to us is again the proliferation index. It's very important that if we have a MIP or Ki67, which is very high, we should all treat them irrespective of morphology as a high aggressive large cell lymphoma. Now, this is very interesting. We do use in clinical practices lymphocyte count and lymphocyte monocyte ratio. So low lymphocyte count is associated with poor prognosis. It may have implications as more and more immune-based therapies are coming. So this ratio becomes important. Now, can we preempt or prevent relapse? That's $1 million question. So as I had said, R-CHOP, whatever comes, we hear a lot about many regimens coming, but they never stand test of time, and R-CHOP still remains the gold standard. You had RECP cut down on the duration to R-CHOP 14. EPOCH-R, other than double hit and primary mediastinal B-cell lymphoma, it has not shown to be more effective than R-CHOP. Some people have tried 8 cycles, it did not. Obinutuzumab came with a lot of fanfare, but truly speaking, no additional advantage over rituximab. So R-CHOP still remains the gold standard for DLBCL for initial diagnosis. So this is the trial. This paper came out in 2019 with whether we add, if we add etoposide to R-CHOP. So the drawbacks in this were there were very few double hit lymphomas to conclude that the R-CHOP and DEPOCH are similar. Now, what important thing is the higher IPI, the IPI 3 to 5, have an advantage if we escalate the things. So the bottom line is more aggressive the lymphoma, younger patient, it makes sense to add etoposide to CHOP. Now, can we add a third agent? So this is very interesting because most of us are looking for adding on one more agent if we come across a non-GCB type DLBCL. So I would focus on 3 agents, that is ibrutinib, lenalidomide, and bortezomib. Venetoclax has also been used, but that's not really available to us. So this was a trial, double-blind placebo-controlled trial, R-CHOP or R-CHOP plus 560 milligram of ibrutinib. This is a non-GCB DLBCL, which was determined by IHC. Now the primary endpoint was event-free survival and non-GCB and ABC subgroup, and secondary endpoint was PFS. Now, if you see the curve, the top curve is where we have added ibrutinib. Now, ibrutinib, when added to R-CHOP, improved EFS and OS, but only in patients less than 60 years of age. Now, EFS benefit was consistent across most subgroups for the baseline factors, and it was seen in patients with the ABC subtype. Now, this is important. So if you have a younger age group and ABC subtype, you can think of adding ibrutinib to R-CHOP. Now, the other agent which we have freely available is lenalidomide. Now, if we add R-CHOP, lenalidomide to R-CHOP, overall, it doesn't seem to be very effective. Both the curves are almost similar. Now, there is a hint that if you see both the curves are almost similar, the p-value is also not significant. PFS endpoint was not met, and CR rates actually were high in both the groups. Now, the only thing is that if the IPI is more 3, then there is a hint that it might be more effective, but nothing concrete in evidence in favor of lenalidomide. Now, this is the recent paper which is going to be, this is the abstract which I picked up from this year's ASH, which is going to be presented. This is very interesting, which shows that 5-year survival results of, this is the remodel B trial. Initially, they said that there is no advantage of adding bortezomib to R-CHOP, but Here they have said if they have classified into 3 groups: ABC, GCB, and molecularly high classification group, which is very poor prognostic marker. So they said that in these specific groups, if we add bortezomib to our CHOP, it will